The hidden risk no one tells you about before surgery. There exists a phenomenon that medical professionals have quietly observed for decades, something that occurs following surgical procedures, particularly affecting those in their later years. This is not about infections or complications from the incision. This concerns the medications that induce unconsciousness during operations. If you or someone dear to you is approaching 70 years of age and facing a scheduled medical procedure, understanding what I am about to explain could prove invaluable. There is a critical question that rarely gets asked, one that your medical team might not mention unless prompted. By the time you finish reading this, you will know precisely what to ask and which alternatives exist to safeguard your most vital organ. When people learn they require surgery, their attention typically fixates on the procedure itself. They research the physician's credentials, investigate recovery periods, and worry about healing. These concerns are entirely valid and understandable. However, through years of clinical observation, I have witnessed a pattern emerge. For patients beyond 70, the surgical procedure itself often presents less risk than the method used to render them unconscious during it. Specifically, the concern centers on complete unconsciousness, where brain function becomes chemically suppressed to profound depths. A breathing tube gets inserted, and mechanical ventilation takes over natural respiration. A 40-year-old typically recovers completely. Their system rebounds quickly. Within days, they feel normal again. For someone past 70, however, this chemical shutdown can trigger lasting changes that persist long after physical healing completes. The essential question becomes, how will my brain be protected throughout this experience? Let me explain the biological reality clearly. The brain of someone at 70 differs fundamentally from that of someone at 40. This is not about intelligence or capability. This concerns what researchers call cognitive reserve, the brain's capacity to withstand disruption and return to its baseline state. Younger individuals possess substantial reserve. Older individuals have less. The margin for error becomes genuinely narrower. When complete unconsciousness gets administered, we deliver multiple pharmaceutical agents. These substances bind to receptors throughout the entire nervous system. They do not gently relax you. They systematically suppress brain function, including regions controlling memory formation, spatial awareness, and sustained concentration. In patients beyond 70, the liver and kidneys process these medications more slowly, sometimes significantly slower. The drugs remain in the system longer. Recovery extends in unpredictable ways. In approximately 30 to 40% of patients over 70, something appears within the first 1 to 3 days following surgery. Medical professionals call this postoperative delirium. This is not a minor side effect. The person awakens disoriented. They may not recognize their location. They might believe themselves at home or in a place from 30 years past. Some become agitated. Others become unreachable. Occasionally, they perceive things not actually present. Sometimes they fail to recognize family members standing beside them. One family member described her father after knee surgery this way. He looked at me like I was a stranger. He knew my name when I said it, but his eyes were somewhere else entirely, like the person I knew was behind frosted glass. Families expect their loved one to be drowsy but oriented. What they encounter instead can be genuinely frightening. Here is what you must understand about delirium. In a significant number of elderly patients, delirium precedes something called postoperative cognitive dysfunction. Memory does not fully return. Processing speed remains sluggish. The mental sharpness present before surgery, that clarity, that quickness, the ability to track multiple things simultaneously, to recall names effortlessly, to follow conversations without losing focus, becomes diminished. Sometimes for weeks, sometimes for months. In some cases, evidence suggests the decline never fully reverses. Consider the practical meaning. Someone driving independently before the operation, managing their own finances, cooking for themselves, living fully. Afterward, family members quietly move in to help. Conversations happen behind closed doors about assisted living. The surgery meant to improve quality of life instead becomes the marker when everything changed. Why is this still not standard practice everywhere? Why do so many patients over 70 still receive complete unconsciousness when alternatives exist? When patients raise concerns, they sometimes hear responses like, "This is standard procedure," or "Do not worry, you will be completely safe." The problem is that standard protocol was designed for average patient populations. When you are over 70, you are not in the average category for risk. You occupy a different physiological category requiring different approaches. Let me provide you with 4 specific techniques, each matched to different surgery types that allow major procedures without deep brain suppression. First, peripheral nerve block pain. Signals from any surgical site travel through specific nerve pathways before reaching the brain. The shoulder, knee, hip, hand, foot. Each region is served by identifiable nerve bundles following predictable routes. Using real-time imaging technology, we place medication adjacent to that nerve bundle. The result is complete numbness of only the surgical region. The patient remains awake or rests in very light drowsiness, nothing like unconsciousness. The brain is not suppressed. No breathing tube, no ventilator, no chemical shutdown. The patient breathes independently, maintains their own airway, and can respond if needed. The block continues working 12 to 24 hours after surgery ends, covering that critical first recovery day. For hip replacements, knee replacements, shoulder repairs, and hand surgeries, this approach genuinely transforms how we protect elderly patients. Second, epidural technique. This is appropriate for larger operations involving the abdomen or chest. A thin catheter gets placed just outside the membrane surrounding the spinal cord. Through this catheter, numbing medication is delivered continuously throughout the operation. The result is that dramatically less general medication is required. The brain is largely spared deeper chemical suppression. The catheter remains for 2 or 3 days after surgery. Postoperative pain is managed continuously with a fraction of the medication doses otherwise needed. Third, spinal method. This is the preferred approach for lower body surgery, hip fractures, knee procedures, bladder and prostate operations, lower abdominal repairs. A single, carefully placed injection delivers medication into the fluid surrounding the lower spine. Complete numbness from approximately the waist down results. The effect typically lasts 2 to 4 hours. The patient can rest quietly, listen to music, or doze lightly. The brain is not chemically suppressed to deep levels. Fourth, conscious sedation. This approach works for smaller procedures, cataract surgery, hand operations, minor repairs, certain skin procedures. The patient receives carefully measured sedation, producing a relaxed, calm state. If someone says your name, you respond. You remain aware at a gentle level. You are not unconscious. For cataract surgery specifically, a procedure taking less than 20 minutes, many elderly patients still receive complete unconsciousness purely from institutional habit. Conscious sedation is perfectly adequate, gentler on the aging brain, and allows going home the same day, often feeling nearly normal within hours. When you sit down with your surgical team before the operation, say this: "I have read about the cognitive risks for patients over 70. Can we discuss whether a regional approach is appropriate for my specific procedure to reduce the risk of postoperative cognitive complications?" This signals that you are informed and opens genuine clinical conversation rather than reflexive reassurance. If the answer is that complete unconsciousness is truly necessary, ask why. What specific aspect of this surgery requires it that alternative techniques cannot address? That is a fair, specific clinical question deserving a fair, specific clinical answer. If what you receive instead is "this is just what we do routinely," without further reasoning, request a separate consultation with the specialist who will be managing your unconsciousness directly. Picture 2 patients. Patient 1, a 78-year-old man, sharp, independent, drives himself to appointments, manages his own finances, does the crossword every morning. He has a knee replacement under standard complete unconsciousness. 3 weeks after surgery, his daughter calls. He got lost driving to the pharmacy he has used for 12 years. He forgot a detailed family conversation from the day before about something that mattered deeply to him. His crossword puzzles sit abandoned. He is not the same person who walked into that operating room. Patient 2, an 81-year-old woman with a hip fracture. We perform the repair under spinal technique with light sedation. During the procedure, she talks with her daughter. She asks about the grandchildren. She makes a joke about the paper cap. By day 2, she is walking with assistance. By day 4, she is home. 1 week later, she telephones to say thank you. She is back in her garden. Her mind is completely clear. I have watched both stories play out in different forms more times than I can count. The difference often comes down to a single conversation that either happened or did not happen before the operation began. Before your next surgery, write these 4 options down and bring that paper to your consultation. Write the question down too. Ask it. Have the conversation before you are in the operating room, not after. Informed patients receive better, more individualized care. A patient who asks specific, knowledgeable questions prompts specific, considered responses. It genuinely changes the dynamic. It invites your team to think carefully about your individual situation. Every patient is different. Every procedure is different. What I am providing is the framework for a better, more informed conversation. The starting point, not the final word. Take care of yourself and protect what matters most: your mind, your independence, your quality of life. The surgery protects the body. The right approach protects the mind. And at 70, at 75, at 80, your mind is worth fighting for.